There we go. You hear me, Brian?
Yes, I can hear you. Gavin, did you want to go ahead?
You're muted, Gavin.
Yeah, thanks, Dr. Lai. I think we're just going to give it a minute here for the attendees to get a chance to all populate. So I'll start the webinar in just about 1 minute. I can see there's attendees joining right now.
The longest minutes in my whole life.
I'm sure.
Cheers. It's water.
Okay, well, I think we'll let people sort of trickle in as the webinar gets going. Let me say thank you to everybody who's on tonight. We've got a great presentation here and an eminent presenter, so we're really fortunate. So my name is Gavin Nelson. I'm the chair of Northern Hearts. Just to give you a little background on Northern Hearts, we're a Thunder Bay-based nonprofit charity whose mission is to provide the public with educational resources and heart healthy programs to reduce the impact of heart disease in Northwestern Ontario. We offer a number of talk with docs throughout the year. We have the Walk with Doc that takes place in June and another one in September as well. And a couple of housekeeping items. So the webinar tonight is being recorded. We'll post a link on our webpage, www.northernhearts.org, following the completion of the webinar. For the presentation itself, there is an opportunity for everybody to ask questions. If you just go down to the bottom of the Zoom controls, you'll see Q&A. So you can enter your question in there. And what we're going to do is just accumulate the questions, and then we'll have Dr. Lai answer them at the end of his presentation. So please feel free to ask away. We will get to most every question that we can. So tonight's presentation webinar is COVID-19 and your heart. Obviously a very prominent subject right now, and we're very fortunate to have our presenter, Dr. Chris Lai, who also happens to be a co-founder of Northern Hearts. Dr. Lai is a Thunder Bay-based cardiologist and a visionary physician leader, recognized for spearheading the implementation of numerous advances in local cardiovascular service delivery. He leads and advises diverse interest groups, including First Nation communities, to promote healthy lifestyles through education. He engages health educators and researchers to advance knowledge in the cardiovascular disease management, and partners with leading institutions to bring services close to patients. I've known Dr. Lai for a number of years, and we're very fortunate to have him. He's done so much for this community. And again, he's a founder of Northern Hearts. We're really thankful to have him back because he's a big part of this organization. With that, I'll pass it off to you, Dr. Lai.
Thank you, Gavin, and thank you to Northern Heart to organize this talk. And also thank you to Brian McKee to help me about the IT, which I'm not very good at it. And also thanks to Dr. Andrew Affleck, who's a board member of Northern Hearts, and also the medical advisor who invite me to speak into this evening's event. I also would like to extend a thank you to all the participants who listened to the talk tonight. And start with this, I will say the good evening to all and Li Hao. And if you see this, the first slide on top of the of your screen, this is the latest picture of Mars. And the bottom right corner in here, that is the picture of COVID-19, or so-called SARS coronavirus 2. You can see the similarity between the two, like a round ball, both of them are, lots of things sticking out. And most importantly, both are very foreign to us, even though that we have been on Earth for so many years, but yet we recently discovered the SARS coronavirus number 2. Okay. Just minor hiccup. Okay. I start with declaring no conflict of interest in these presentations. And this is I'm going to present a case to you in the real world, and that lead to further discussion with you folks later on. This is a case presentations of a 65-year-old fellow who is perfectly healthy and just a touch of hypertension, or high blood pressure, but otherwise pretty healthy looking. So in March 2021, he received vaccinations, Moderna, and in April the 20th, he received the second dose. Shortly after receiving the second vaccinations, he had generalized non-specific complaint with generalized unwell, chest pain, pruritic in nature. When they try to take a deep breath, it hurts. When they lie down on the couch, it hurts. He also diffuse muscle aches, tired, no appetite, and he had mild grade fever. Then in July the 28th, he went to the emergency department, and he has a so-called negative PCR test for SARS coronavirus 2. In his swab, you also have a positive for rhinovirus and enterovirus. This is important. We'll explain to you why this is important later on. He then have a chest X-ray done, and he reported there's no pneumonia, but his heart is a little bit enlarged as compared to normal. He continued to have those vague symptoms that he eventually went to Mayo Clinic on August 8th for a second opinion. He was hospitalized for 5 days and then had many tests and many procedures done, eventually to diagnose him to have a viral pericarditis. While he was still in Mayo Clinic, he was treated with a standardized protocol of using colchicine, which is for gout, and also indomethacin, which is an anti-inflammatory agent. And he continued his blood pressure medication in the metoprolol, candesartan, and hydrochlorothiazide. He then arrived back to Thunder Bay, and then he referred to see us. I saw him on September the 3rd. And yes, after talking to him, examining him, I concurred that the diagnosis of viral pericarditis is likelihood. That is the thing. But what virus is it caused by? I'm not sure. So I said, okay, well, you take the same medications, and I'm going to see you and do some tests and find out what's wrong with you. So the tests we ordered on him, one, we had chest X-ray. Again, the chest X-ray showed that he had no pneumonia at all, and he just had an enlarged heart. Here's a muscle scan performed. A muscle scan is a nuclear test done in the Thunder Bay Regional Health Science Center to see how good the heart is contracting. And then magnetic scan showed we call ejection fractions, which is this a measurement of how strong your heart is contracting. If 46%, normal should be more than 50%. 10 days later, you have an ultrasound of the heart, we call echocardiogram, and the ejection fraction measured 53%. So it's improving steadily. During that time, the echocardiogram did not show any fluid around the heart sac, we call pericardial effusions. The pumping or the movement of the heart is completely normal. So that's good news for him. We also have ordered some blood tests on him. The blood tests are really unremarkable. All his inflammatory markers are normal. Then we do the stress test on him to see what is happening to this fellow. So on November the 30th, he have a stress test done. The stress test, actually, he did quite well, 12 minutes, which means he's quite fit for 65 years old. But if it's not completely normal, per se, we call it non-diagnostic test. So we order further testing on him, including a stress image test and the cardiac CTA. The cardiac CTA, which is the CT scan of the coronary artery of your heart, it just showed that he just minor plaques and nothing significant per se. There's no significant blockage at all. The nuclear test or stress image test, we call it percentage cardiolite. It was done, and it was shown that the no signs of lack of oxygen in his heart. There's a but there. The but is his ejection fraction now is down to 20%. Remember, it is normal, and then further down to 20% now. At that time, I asked him what is happening to him. Well, two things happened to him. One, he stopped taking his medication called metoprolol because he felt tired. He read from the book that, well, metoprolol causes fatigue, tiredness. So he said, I'm not going to take that anymore. I'm so tired. On January the 4th, he also felt unwell. He tested positive for COVID-19. That's 6 days before the nuclear test is done on him. So we tried to put all the things together for him. So I thought he most likely has so-called Perimyocarditis in July 2021. Is it due to the vaccine? I'm not sure. Is it due to the virus? I'm not sure either, but he's the virus. What kind of virus is that? Well, he has a negative so-called PCR test, so unlikely to be coronavirus, so-called COVID-19. But remember, we said in the few slides back, we also found that he had two other viruses in his nose. One of them is called the enterovirus. Enterovirus usually give you diarrhea, stomach ache, and within that family of enteroviruses, one of them is called Coxsackie virus. The Coxsackie virus certainly could cause a perimyocarditis. The second thing that I thought he has is a relapse of the perimyocarditis in January 2022 because of the fact that his ejection fraction was down to 20% as compared to previously he was up to 50%, although when he was in Mayo Clinic, his ejection fraction was 37% only. So putting all those together, the second time that in January 2022, he has relapsed of the perimyocarditis, I believe that likelihood is due to COVID-19 because he had positive test at the time. So I told him, look, you should restart on the metabolo and see how you feel, because he otherwise okay. During that time, he asked me, Doc, should I have a booster vaccine? What I'd like you folks to do is to vote for me. Some cases say yes, he should have booster vaccine, or no, some of you say no, he shouldn't have a booster vaccine. I'm going to pause in here, and you can start putting your vote in, and we'll see what is the general consensus from the audience are. Okay, choice 160. I'm going to read that out to you when it stopped counting. He's still counting.
On the poll, choice 1 would be yes, and choice 2 would be no, just for clarification.
Thank you. Don't be shy. There's no right or wrong answers until later. Okay, I think I'm going to end the poll in here in 2 seconds. Anyone want to enter your poll? Do it now or else. Okay, I'm going to end the poll now. The poll said, actually very, very close. 52% say yes, and 48% say no. Interesting, isn't it? All right, I'm going to end the poll now. Good. Interesting exercise. Okay, now let's go to the next slide. Okay, so for those who say yes, then when should we give him the booster shot? According to all the scientific data, individuals like us, like the fellow that we have, who have fully vaccinated, but yet he still have COVID-19. So you should wait for about 3 months after you have settled down with your COVID symptoms. In my opinion, for my fellow, I did advise him to say no, because of the history that he has a perimyocarditis. Pericarditis, which is inflammation around the heart sac, and also inflammation in the muscle of his heart. That's why I said there's no right or wrong answer earlier. Well, let's look at what the incidence of vaccine-related pericarditis or myocarditis. You look at the journal in JAMA, a Journal of American Medicine Association, they look at 2 million people, is 1 in 100,000 who have myocarditis. It'll occur about between 3 to 10.8 days. Majority of those people are male at the age of 26 to 48. You look at pericarditis is 1.8 per 100,000 vaccine being related, usually occur between 6 to 41 days. Again, predominantly is male at the age of 46 to 69. You look at CDC in June 2021, CDC reported 4.8 per million, which is 0.48 per 100,000 of vaccine-related myocarditis. They certainly look like they are under-reporting per se. You look at the latest Danish study published in British Medical Journal, and in December 2021, 4.1 million people have been studied. And their chances is 1.7 per 100,000 vaccine-related. It is slightly lower in Pfizer group, slightly higher in the Moderna group, which is that's one of my patients that we presented to you tonight. What about if you have COVID? What is my chance to get pericarditis or myocarditis? In the USA, in JAMA again, in May 2021, it's 2.3%. In Iran, August 2021, is 1.2%. So bring it to the so-called normalize it. You have 1,200 chances to 2,300 chances per 100 patients for have a COVID infected in your heart, versus vaccine-related is only 5.7 per 100,000. So you can see and appreciate that the vaccine-related perimyocarditis, inflammation of the heart sac and also in the myocardium, is less than 200% than related to the COVID disease related. So even though there's a chance when you get vaccine to have pericarditis or myocarditis, still it's a much lower chance as comparing to when you get COVID-19. Let's pay attention to the impact of COVID-19 on local cardiac care. I'm quite lucky that this data have been shared with me by the Thunder Bay Regional Health Science Center, and quite thankful that they share the information with me. Let's say that we say that COVID pandemic or occurring on December 2019. So this 2 years data, 2018 to 2019, 2019 to 2020, we can call it pre-COVID. This data, 2021 data, will be during the COVID time. As you can see quite vividly, 713, 695, and during COVID, we're down to 643. You look at the trend, is from 704 all the way down to 643. You take the average of these two. So there is about 8.6% of decrease of admission for acute heart attack in our hospital in here. Well, let's look at the heart attack. There are two types of heart attack. One type we call STEMI heart attack. I'm not going to go through what is STEMI heart attack with you folks. Just say that there are two types of heart attack. The first one we call STEMI, the type 1. When you look at statistically, the male to female ratio remain the same before COVID and after COVID. So basically, they are pretty well identical. What about the second type of heart attack, so-called non-STEMI? Again, looking at the male and female ratio, again, they are practically very similar. And the second type of heart attack is the same. When you look at the number of female being admitted after the COVID, about 40%. And when you look at combine these together, you have about 41%, so identical in terms of number of female being admitted. Let's look at the age of the patients then. The age of the patient, they are a bit older in terms of the increasing in the second type of the heart attack. Obviously, everyone would like to know what my chance to die at discharge. So when you look at the trend of so-called cardiac-related death, we divided cardiac-related death and versus non-cardiac-related death. Well, non-cardiac-related death, like you have a pneumonia, so it is not related to your heart attack, you didn't have a cardiac arrest, etc. So we call it non-cardiac death. And certainly, when you look at the second type of heart attack, so-called non-STEMI, you can see that it goes from 1.7%. You combine the two together, it is 1.3% all the way up to 2.6%. So which means it's a double of the heart attack cause of the death from cardiac disease after you have a heart attack. But this first type of heart attack called STEMI really remained the same. There are no significant changes. So when we look at the non-cardiac cause of death, as I said earlier, maybe you had pneumonia causing the death rather than a cardiac rupture or something. It's also true for the non-cardiac death, i.e. the trend is higher in the second type of heart attack. It's from 0.4% all the way to 1.3%. You combine those data together, the 2 years together, it will be 0.6% up to 1.3%. The first type of heart attack remained identical. So how should we interpret this? Well, what we could interpret that is the total number of heart attack admitted in the hospital was decreased by 8.9%. And the people who admitted in the hospital during COVID and they have a heart attack are older. The cardiac mortality rate is 1.3, increased to 2.6%. The non-cardiac mortality rate is from 0.6%, increased up to 1.3%. So we see the trend, people are not doing too good, although the number of heart attacks coming into the hospital is lower. My hypothesis are, well, people are more reluctant to come to the hospital during COVID, and the number, reflecting on the number, they're lower. They're coming in later and sicker because they really don't want to come to the hospital. And for those who come to the hospital are having more comorbid problem, namely, they may have lung problem, they have diabetes problem not under control. Therefore, the cardiac and non-cardiac mortality certainly increase. Obviously, this is a small hospital, so we're only looking at one hospital trend. The limitations, it is a 2 years data versus 1 year data pre versus during COVID. My take-home message to you is common sense is most important. I still believe that wearing a mask in public places is vitally important. I still recall about 30 years ago when I went back to China with my niece and my sister. We were so shocked to see people wearing a mask. They said, "These guys are crazy. Why are you wearing a mask for?" Wash your hand after a handshake is very important. I always carry a bottle of hand sanitizer in my pocket, So every time, I don't mind to shake your hand, but I will wash my hand. When you cough or sneeze, cover your mouth and nose is very important. If you know you're sick, don't feel well, if you have a flu, what do? You stay home. You don't come to work and spread the germ, not your well. Finally, I believe that you should all get vaccinated, although there's a slight chance to get perimyocarditis from the vaccine. And most importantly, we do treat everyone is a positive carrier, so you know how to protect yourself. I'm going to stop in here, and we have a few more minutes left, and you can ask me questions, and I can answer you as much as I can. Thank you.
Thank you very much, Dr. Lai. It was a very interesting presentation. Again, if there are questions, please feel free to ask them in the Q&A box. Just to sort of get it going. So Dr. Lai, would the pericarditis, myocarditis sort of be the most prominent potential side effects related to the heart then for COVID and for vaccines? Is that?
Related to heart, yes.
Yeah.
But there are many other so-called non-specific symptoms, like this fellow that he has. Why? Even myself, I can tell my personal experience when I get my booster shot from Moderna. My wife and I was in bed for one day because we still, boy, do we ever feel tired. We are not much energy, no pep. We planned it in a way that we're going to have the booster shot on a Friday. So on Saturday and Sunday, you know, if we are so-called down day, we can lie in bed and do nothing and watch televisions. And that's what we did. And there are many other, site injection, painful, etc. Usually they are quite transient, last about a day or two, and you should bounce back quite nicely.
Okay, we've got a couple questions from the attendees. So the first question from an anonymous attendee, has COVID-19 disrupted the way your clinic operates? Are tests harder to administer now?
Okay, thank you for the questions. And one is looking from the business point of view, certainly it costs more money for the operations. Why? Because we want to protect our staff. All our staff wear masks, all our staff will, especially the technical staff that who are doing procedure on you, they all wear gloves and their shield, they're protecting themselves and also protecting you from them. So in a way that in the operative part, it is a bit more costly. In terms of efficiency, initially, certainly, no doubt, we have a learning curve to deal with. How much question you're going to ask, what kind of question you want to ask, and you take a body temperature of that individual. All those things are slowing down in terms of the processing part. It certainly COVID-19 has impacted us. Initially, we're down to about, I would say, 20% of people who show up for the visit because of the fear of catching COVID in our clinic. Similarly, you can see that the trend of the heart attack also coming down because of the fact they don't want to go to a hospital, and therefore you're going to have lower number. It's similar, we have much lower number in the initial phase of the COVID-19.
Okay, great. Next question. So it's how long will the heart palpitations and chest pain take to go away after having had COVID-19 sort of late December, around December 22nd?
The symptoms, how long they're going to last is quite variable. Majority of people, let's say, for example, your heart problem is due to COVID-19. Let's say, for example, I'm not vaccinated and I catch a virus, and by chance that I also have involving the heart sac that I have, so they call the pericardium, and also affecting my muscle, your heart, so-called perimyocarditis, and then it's going to take at least 8 to 10, even 12 weeks before I recover. If I had to go to see the doctor early, if the doctor give me appropriate medication to take. So quite variable, depending on your immune system, how to fight off those vaccines. I'll give you a good example. I'm sure that some of you may have cold sore or more bad thing called genital herpes. Those viruses always live inside our cells because viruses cannot duplicate themselves. They die on the surface because they cannot survive. They need to be in either plants like apple tree or animal like chicken, bat, or human. So we do have lots of viruses inside our body that we're fighting off all the time. If you know someone who has cold sore, they will tell you that, well, when I feel down mentally, when I feel down physically, my immune system coming down, my cold sore can come out. And that's saying that viruses are very, very, some of those, they really hibernate inside our body. Talk about that, the hibernations. I'm sure that majority of you know that there are so-called nucleus DNA that in our body. The nucleus DNA is we inherit from our parents, 50% from the mother, 50% from our father. Do you know there's another type of DNA inside our cells we call mitochondrial DNA? The mitochondrial DNA has been in our cells for many, many years. And that DNA, called mitochondrial DNA in the mitochondria, where we make energy, so-called, I call it where the bank prints money for the energy for the cells. And that mitochondrial DNA, from all the scientific data, we still don't know where it's come from. Hypothesis is that there is such a thing called the DNA virus. Many thousand years ago, to 50 million years ago, 8,000 years before Christ was born, we call those DNA incorporate into our body, and that's why I call mitochondrial DNA. So understanding there are two types of DNA within your body. The second type, we're not too sure where it comes from. We blame it on a DNA virus.
Okay. So the next question. So just my booster was a half dose, and I wonder if I should have had the full dose. I've had a stent implant and heart attack.
Mm-hmm. Okay, now let me bring you up to the slide. I'm going to end the slideshow in here. I'm going to show you something else if all possible. And that is, okay. And you only see my black screen there, did you? Everyone? All right, good. So, 65, I'm going to locate my slide for a couple of minutes. Just give me a second. Mm-hmm. So, your question is, what should I do? Should I get a full dose or should I not get a full dose? Let's look at who are at risk. Well, on February the 7th, 2022, the most people that who die from COVID-19 is over 65 and up. So you also look at dividing those people and look at long-term care facility, again, account for more than 35% of the, could you see that now? Could you guys see the slides?
Yep.
35% of all COVID death. So what is the underlying risk, the increasing my chance to die from COVID-19? We call underlying medical conditions. And the underlying medical condition, they come to the top with cancer. Obviously, chronic lung disease, chronic kidney disease, liver disease, etc., diabetes, all those are predispose you to have higher incidence of death or due to COVID-19. Obviously, that if someone who has heart failure in particular, or coronary disease in terms of heart attack before, or some form of cardiomyopathy, certainly make it more prone to have severe problem when you contact COVID-19. So really depending on the individual, with the risk factor, whether you should have full dose, second dose, third dose, fourth dose to get the booster dose of the COVID-19 vaccine. So certainly I'll recommend it. You should talk to your doctor about it and see whether what category are you in terms of your risk factor when you contact COVID-19.
Okay. Next question, and we've had a couple different iterations of what is sort of a similar question, and it's how common would you say are heart issues associated with post-acute COVID sequelae, also sometimes called long COVID? So what are the heart issues associated with long COVID that have been identified?
Long hauler, majority of those people will have lung problem. Remember COVID-19, the virus that causes COVID-19 is called a SARS, so-called SARS virus, COVID coronavirus. Second, they cause it majority of the time in the lung tissues rather than the heart tissues. So majorly, the long hauler is the lung problem rather than heart problem per se. Majority of the time that when you have heart-related, i.e. perimyocarditis, you normally will recover from the disease that you have. It's a lung that's been damaged, cannot be recovered as much as the heart muscle. Understanding heart muscle very resilient to disease. Why? Because we do have so-called stem cells inside our muscle of our heart. So if the muscle been damaged, the stem cell will be stimulated to replenish making more new muscle of your heart. Hasn't been reported at this present time involving the heart valve directly. What I mean by that is if they're unusual to have pericarditis, i.e. involving the pericardium, involved in muscle, and involved in the heart valve, there are yet to see a reported case involving the heart valve.
Okay, great. Thank you for that answer. So just sort of another question here is I've had 2 Pfizer vaccines as well as 1 booster. I contracted COVID 2 weekends ago and isolated from Monday last week until today with head cold type symptoms as well as muscle aches and fatigue. Although those symptoms have passed, I'm left with shortness of breath and tire easily. Should I be concerned?
Mm-hmm. Again, depending on your underlying risk factor that you have, I'm going to share with you, if possible. I'm going to try and see whether, okay. What are the higher risk for death from COVID-19 then? As you can see, depending on what age group you're in, the older you are, let's say 85 years old, the risk for you to die from COVID-19 is about 10 times as versus the younger group. They do die, but yet relatively slower. Again, when you look at the risk factor, when I'm going to die or how bad it is, it depending on the comorbid problem you have, how big I am, how obese I am, how much diabetes I have, what kind of kidney problem do I have, what kind of lung problem do I have, what kind of so-called neurocognitive problem do I have, or do I have heart disease, how bad is my heart disease? So all those will causes increasing the chance to die from the heart disease. Obviously, the more comorbid problem you have, the more likelihood you can die from COVID-19. Let's say, for example, in year 2 to 5 of those conditions that we talked about earlier, you're 2.6 times higher comparing to one that who no comorbid problem. You can see that it is certainly depending on your underlying health rather than just COVID-19, I'm going to die. No, you depending on your number of comorbid problems that you have.
Right. I guess sort of along these lines, one of the questions was, I tested positive for COVID. Should I be making an appointment to see my cardiologist to see if my damaged my heart?
Well, interesting. You ask these questions in our offices now. We at least see 1 or 2 patients at least a day to have certain type of so-called chest pain and palpitations. Those are 2 commonest so-called, whether due to COVID vaccine related or whether because we're so scared of the COVID vaccine that causes those symptoms. I would say majority of those are quite benign problem. If you're worried and concerned, the first thing you do will be talking to your primary care provider, like your nurse practitioner or like your doctor, and they will decide that, yes, I think you should have an ultrasound your heart done, or I think you should have an electrocardiogram done, or you can think that you should see a specialist about it. So really the first step will be, do I feel comfortable with what I am? If I'm not, let me talk to my primary care provider, the nurse practitioner, or the family doctor, and then let them guide me to whether I need further testing or referral or not.
Right. Okay. Couple of general questions, and you can sort of answer these however you feel. So are most cases of COVID in our ICU vaccinated or unvaccinated rather? Are you aware of any statistics on that? I don't know if you're comfortable answering that.
At this present time, I'm unable to share with you the number of people in our intensive care unit, whether they are vaccinated or unvaccinated. At this present time, we have to get permissions from the Thunder Bay Regional Health Science Center before we can share those data outside. So I apologize, I'm able to share with you. But when you look at the generalized data from the United States now, not from Thunder Bay Regional Health Science Center, majority of people that who has been admitted intensive care unit, let me qualify again, This is a data from United States, not Thunder Bay Regional Health Science Center. Majority of them are unvaccinated. But again, understanding this is not in Thunder Bay Regional Health Science Center, the data I just mentioned to you.
Right. And sort of back to the original presentation, I guess, how any update on how the gentleman that you had highlighted in the presentation, what the outcome was, or is it still ongoing?
Good questions. We are repeating some of the blood work on him. We're repeating the ultrasound of his heart to see whether he recovered. Remember that two things happened to him. One, he stopped his medications. And two, he tested positive for COVID-19. So we are not 100% sure whether this is COVID-19 related or because he stopped his pill. So it's hard to say, but yet it's ongoing. But he feels great. He feels good now, although he feels tired, but he did not have any symptoms related to the dysfunction or not function well of the muscle, his heart. I will keep you posted when he comes back to see us after all those tests been done on him again.
Right. Okay. I think that's it for the questions right now. Actually, there was several people have had a fourth booster. Is the fourth more adventurous than the third? I'm not sure if you have any insight on that.
It's a great debate in my own mind. My wife and I were talking about this 2 nights ago. Should we go for the 4 vaccinations or the third is enough? Should we have the vaccination once a year? We both vaccinate for flu vaccine once a year, but should we get a vaccine from COVID-19 once a year? Those are very, I would say, the unknown questions. Understanding that when you receive a vaccine, the 2 things happen to you in your body. One, you build antibody against the virus. And that is a so-called a curve and then come down and slowly down. And when you're going to go up, maybe rechallenge, etc. The one thing. 2 is a second type of defense mechanism that we have in our body. We call it lymphocyte. One type of lymphocyte we call T lymphocyte. The T lymphocyte is a little cell inside our body, one type of the white blood cell that we have. That T lymphocyte have good memory. They remember what the COVID-19 virus looked like. So when those COVID-19 virus coming in with those stickers coming out, those lymphocytes will come and start like a Pac-Man, tap, eat it up. So there are 2 types of defense mechanism that we have in terms of our body against any type of viruses.
Right. And there is a question just around the different vaccines. So this individual had Moderna vaccine in April, became quite ill after it. Feeling better now. Should they take the Pfizer for the second vaccine and the booster and not the Moderna?
That's a very good question. How long do we have, Gavin? What time is it now? We have 5 minutes. Okay, I'm going to.
You're in the control. You're in the control here, Dr. Lai. So
we're going to run through very fast in order to understand what vaccine means to you folks. Some of you may recognize these pictures. And there's a British physician called Edward Jenner. He's a pioneer for smallpox vaccinations, and he was vaccinating a child. But there's a but there. The but is the first vaccine for smallpox really not developed by the British guy. He developed a Chinaman, and that he gave children with the crust of the lesions of people suffering from smallpox and protect the child from getting smallpox vaccine. Since the British physician Edward Jenner, he developed many things happening, and so more and more type of vaccine had come out. Vaccine could be also against bacteria, not just virus. You have to understand vaccine, which means it's something that against lots of things, including venom against other venom. The vaccine could increase venoms and other toxins. And there are many types of vaccine that have been coming out to try to fight the different types of disease that we have. I'm not going to go through how the vaccine being formed, but just to say that there are many types of vaccine being done, and some of them are like subunit of the vaccine from a protein made from the surface of infected agent. Example will be the influenza and also the hepatitis B. Again, as I said, there are certain types of vaccine called viral vector vaccines, which is formed by Ebola, i.e. that you put a vector, which means carrying a harmless virus, to go into our cell and stimulate our cell to go against the virus. If you recall, not long ago, before the race on for who developed the first, who can produce the first SARS, COVID, coronavirus 2 vaccine, the German group, unfortunately, they used HIV particle virus, but it didn't work out the way they want to. The type of technology that we make the vaccine, there are many types. Obviously, the most recent type is the messenger RNA virus that we make the vaccine using a messenger RNA. What it means by that is, let's say you climb a ladder. You cut the ladder into half. So you half of the ladder. And that half of the ladder, let's imagine that is an RNA virus. And then you take it out, half the virus, the other half of the ladder, and match them. And then you after you match them, you produce more RNA, and they call messenger RNA, to inject in ourselves to make it as a vaccine. I simplify as much as I can. There are two types of COVID-19 vaccine. Obviously, the messenger RNA type, which is the technology making that vaccine, is from messenger RNA. And that one is the Pfizer and Moderna. There are two viral vector vaccine. One is AstraZeneca and one is a Johnson & Johnson. In Canada, we focus majorly is in the Pfizer and Moderna vaccine, understanding that even though the technology they use, because of two different companies, two different group of scientists, so what they produce may be slightly different from the rest of the vaccines. I'm not going to go through that potential risk there. And basically, when you look at the Danish study, they studied 4.1 million people, only 1.4% per 100,000 will have perimyocarditis, and 5.7 per 100,000 with Moderna. Certainly, it sounds like the Moderna a little bit more complication from Pfizer vaccine. I'm going to stop in here rather than go through how other treatment of the SARS coronavirus 2 is. Okay, any other questions you have?
So just there was one follow-up question. It was around the individual who had 2 Pfizer vaccines and the booster, contracted COVID a couple weekends ago, was isolating with muscle aches and fatigues, and those symptoms went away, and then they're still left with the shortness of breath. So the person just provided some additional background and saying that they're an active 65-year-old female, lost 100 pounds and a subaortic stenosis. So again, they were just asking, should they be concerned?
Well, based on the information you've given to me, the first thing is, well, is your subaortic stenosis, i.e. the narrowing of your left ventricular outflow tract, is it getting worse or not? The first thing that comes to my mind. The second thing will be, well, should I worry? The answer is yes, you should be going to see your primary care provider to make sure that you don't have anything else rather than blame on the vaccine only or blame on the COVID-19 that you have. So the answer to that question in short is yes, go and see your primary care physicians or nurse practitioner.
Okay, well, that's, we're just after 8 o'clock. Was there anything else you wanted to add, Dr. Lai? Just before we close out, I think Dr. Affleck would actually like to make a comment. Dr. Andrew Affleck?
I'll do it at the end, Gavin.
Okay. Sorry, so Dr. Lai, was there anything you wanted to mention before we close out?
No, I think the major message that I always spoken to you about, the take-home messages, but we all have to live. You know that the health mandate is very difficult to follow. I'll give you a good example. If you're driving a car, will you stop at a stoplight? If you're driving a car, you see a stop sign, will you stop? So all those sounds like it's not right. I have a freedom not to stop. I have a freedom not to. I have the freedom to drive through the red light. And I think that's very, very important to understand it. We live in a society, have laws and regulation. We also have to protect each other rather than protecting yourself only. The second thing that I really want to stress to you is prevention, prevention, prevention. I can give you an example. My wife and I visit Amsterdam twice now. The last one is 2 years ago. Every time we go there, we always visit Chinatown. For those who have visited Amsterdam before, you know where Chinatown and the red light district is. The red light district is right at the corner of Chinatown. So the second time, my wife and I, well, let's go and look at what is the red light district like. To walk by the ladies in the window, I knock at the window. I said, ma'am, if I come in, do I need to wear a condom? And then the lady said, yes, it's a prevention, preventing getting disease. And same thing in here, vaccinations is a prevention. It doesn't mean that you will not get COVID-19, but if you get it, you become less sicker. I hope this is something that we all have to think of. Prevention. Thank you.
Thank you, Doc. That is a terrific anecdote. Listen, I'm going to give the floor to Dr. Affleck here.
And thanks, Gavin. Can you hear me okay?
Yes.
Yep.
Yeah. I just wanted to stress what Dr. Lai was saying. I am a semi-retired emergency physician after 35 years in the emerge, and saw the COVID up front, and it was very apocalyptic to me. So the stress about prevention is extremely important. And as we move forward, this is the last virus we're going to see. So I think you'll see masks around for quite a while because we know they work and we know the vaccines work. And when you work in the environment where you see these people, you get to see how well masks, washing hands, and vaccines work. So they're very important. So the other thing I'd like to do is just like to thank Dr. Lai for giving this talk. Maybe somewhat controversial for some people with respect to vaccines and where we're at with COVID, but still I think it gave a very good picture of what's happening to the heart with this virus. And I'd also like to point out and thank Dr. Lai for the many years he was with Northern Hearts. For those of you who don't know it, Dr. Lai was with the founders of Northern Hearts, I believe about 18 years ago or more, and it has gone on. He recently stepped down from the board, and quite sad to see him go, but we did pull him back for this talk. Thank you very much, Chris, for coming back for the talk. And I'd just like to thank you once again for all the work you put into Northern Hearts and made it sustainable. It's just going to go on in the future thanks to you.
Thank you, Andrew. And I agree with you, everything you said. And I hope that people start to live normally as much as you can. As I said, 20, 30 years ago, when I visit China, I thought people are crazy wearing a mask. Now we are saying the same thing, but it's not crazy, it works.
Okay, well, thank you everyone for attending tonight. Again, the webinar will be posted on our website, www.northernhearts.org. And I wish everyone the best, stay healthy, and we look forward to you guys attending webinars that we'll be holding down the road. So thank you, Dr. Lai, and thank you everyone for attending.
Ciao, ciao.
Bye.
Thanks, Dr. Lai.
You're welcome. Bye-bye now. Good
Bye-bye.
night.